Moving on to the case report, a young girl reported to our clinic the chief complaint of having food lodgement and sensitivity with occasional pain only for the past 2 weeks. She already went to 2 or 3 clinics and they suggested only the root canal treatment. So our aim is to restore the tooth to its function, strength and aesthetics. So what to decide whether to continue with the root canal treatment or the pulp therapy? Because the chief complaint is only the food lodgement and the sensitivity with the occasional pain only. So how do I decide whether to go for the RCT or pulp therapy? Based on the investigations. The two main things is wide-beam radiograph and the vitality test. Why wide-beam radiograph? In wide-beam radiograph, the occlusal loader is kept parallel to the occlusal plane so that the X-ray passes parallel to the long axis of the tooth. So it shows the proximity of the caries affecting the pulp. Without wide-beam, everything seems to be close to the pulp only. The second thing is the vitality. Vitality is cold test. Cold test with the endocross. So in this case, after investigation, in this case, the cold test is positive. That is, when I remove the stimulus, the pain is diminished immediately. So the pulp is vital. This is a reversible pulpity, so I can go for the pulp therapy. And also you can see the remaining dentin over the pulp. So after this investigation, I decided to go for the pulp therapy. What do you think? So under pulp therapy, there are two scenarios. One is the direct and another is the indirect. Okay. So when this comes, I usually decide to go for the indirect pulp therapy. Why? Whenever we expose the pulp, we always reduce the vitality of the pulp treatment. To the at least 4 to 5 years it will come down. So I always go for the indirect pulp therapy. So what do you think? What is the best pulp capping agent? Is it dicol or resin modified glass ionomer, MTA or dentin in caps such as biodentin, bonded resin or none of the above? Anyone? No. Dentin itself. So a well-sealed margin and array of caries resin itself is the best pulp protective agent. So the best rule of pulp capping today is do not expose the pulp. Again, do not expose the pulp. So I decided to go for the pulp therapy without exposing the pulp. So how do I decide? I'm not going to expose the pulp. So now how to decide where to stop my cavity preparation or caries excavation? How do I decide? This comes the 3/5 rule. This rule is given by Professor David Alleman, who is considered as the godfather of the biomimetic dentistry. It dictates that caries removal should proceed to a point of 3 mm horizontally from the KO surface margin, that is from the marginal ridge, and 5 mm vertically from the occlusal surface, creating a sound peripheral seal zone around the tooth. And this guideline helps the dentist avoid pulp exposure and leaves a strong base for the bonding, mimicking the tooth's natural protective layers. How do I decide that I achieved the 3 mm of peripheral seal or not? By using a caries detecting dye. I use this dye for two scenarios. That is, one is for where to remove the caries and another thing is where to retain the caries. So at the periphery, I use this dye to remove the caries. But at the center, I use this dye to retain the caries. No matter infected dentin or affected dentin, I always use to preserve over the pulp. So these principles of caries tissue removal involves avoid discomfort or pain and dental anxiety, preserve non-demineralized as well as the remineralizable tissue, achieve an adequate seal by placing the peripheral restoration onto the sound dentin and enamel, thus controlling the lesion and inactivating the remaining bacteria. Maintain the pulp health by preserving the residual dentin, that is, avoid unnecessary pulp irritation or insult, and preventing pulp exposure. And maximize the longevity of the restoration by removing enough soft dentin to place the durable restoration of sufficient bulk and resilience, that is about 5 mm of vertical from the occlusal tip. So during cavity preparation, some of the important words used are fissurotomy bulb. This unit head shape allows to explore fissures and remove the early decay with minimal tooth removal. And another one is the Cera bulb. Usually I use this with the slow spin handpiece. It's a ceramic material primarily used in the dentistry for the controlled and intuitive removal of the caries, that is decayed soft dentin during cavity preparation. And another is cantilever. This helps me to get the saucer shaped cavity line. That is also to get the occlusal bevel. Next comes the immediate dentin sealing. A freshly cut, uncontaminated dentin surface is the ideal substitute for the dental adhesives. IDS creates a stable, stress-free hybrid layer which is the micromechanical bond between the tooth and the adhesive. By immediately sealing the exposed dentinal tubules, IDS prevents a bacterial invasion and the outward flow of the dentinal fluid that can cause pain from the thermal and the chemical stimuli. This stronger and more durable bond created by the IDS leads to fewer clinical failures and higher success and survival rates. Let's move on to the steps in bonding, that is in IDS. First is caries removal endpoint. That is, I am achieving the peripheral seal zone of 3 mm and getting the clean DHA. That DHA is very important here because it acts as the natural marble of the tooth. Second is the micro etching. We do this with the intraoral sandblaster with aluminum oxide of 30 microns preferably. What it does, it removes the water from the infected dentin and also it pushes a smear into the dentinal tubules so that it forms a dentinal plug. Then chlorhexidine 2%, scrub and leave for 30 seconds, then air dry and wash off. Why this chlorhexidine? Because after cavity preparation and sandblasting with the aluminum oxide, the body perceives this as an insult. To protect the pulp, it releases the MMPs, that is, which is nothing but the matrix metalloproteinases, which is a proteinase. It protects the pulp, but it interferes with the bonding. So to avoid this, chlorhexidine 2% is used before we etch. After the chlorhexidine wash, self-etch primer bond, which is the 6th generation bond. This is Clearfill SE bond from Curare. Okay, it has a 2-bottle system. One is the primer and another is the bond. First we use the primer. We used to scrub. We used to scrub for almost 20 seconds and then wait and then air dry. After air drying, we will appreciate that small shiny surface. Over that, a bond is applied, a thin layer, and a new applicator tip is applied to remove the excess, and then by curing. Curing is about for 30 seconds in intervals. The first 10 seconds at a distance, that is to initiate the polymerization, and the next 10 seconds is no cure, that is a dark cure, which helps in the relaxation of the composite during the stress period. And another 10 seconds again curing. This is to continue the polymerization, followed by the flowable phase, which is less than 0.5 mm of resin coat. This is usually done with the high filler content injectable flowable composite. After this, if needed, that is, if any cracks present in the enamel, it goes beyond the dento-enamel junction, we use the fiber reinforced composites. So once the resin coat is applied, wait for at least 5 minutes. This is called decoupling with time. This creates the biobase. Why 5 minutes of decoupling time? Decoupling with time is a technique that involves allowing the dentin bonding system and the resulting hybrid layer to mature and develop sufficient strength before placing the final restoration. The dentin bond and the hybrid layer don't achieve their maximum strength immediately because in the bottom pulp, over that only infected dentin and then the affected dentin, overall the peripheral seal zone. So it takes time to mature. Studies show the bond reaches the 90% of its potential strength after approximately 5 minutes. That is why we are giving 5 minutes of time. This gives you the biobase. After that, the enamel margins are refreshed, followed by the final restoration. The same appointment or the next. If 2 appointments is planned, then we have to temporize the restoration. So after this, we do deep margin elevation if needed. Deep margin elevation or coronal margin relocation is a procedure used to raise or reposition subgingival margin into the supragingival margin using several materials to increase the marginal integrity and also the bonding strength. Soft tissue sculpting. Sometimes the gingiva may be needed to trim to allow the correct placement of the matrix or wedge. This can be done using laser, cautery, bursary, thermocouple or various other methods. I use electrocautery in my clinic. I manage this case with the electrocautery itself. And next comes the injection molding. The steps involved is the first one is the etch and bond, acid etch the thread and all clean the enamel near the restoration, rinse and dry. And then universal bond is applied for 20 seconds into the tendon, earthen gently and then light cure. Step 2 is re-wet with the adhesive but do not light cure. Why? This acts as a wetting agent. Step 3 is the flowable composite which is heated and then over that we use a paste composite which is inject, do not be condensed. Why this injection molding technique is the simultaneous injection of the heated flowable and pasted composite results in the predictable filling of the cavity. So this overcomes the deficiency of the layering technique like whites and also it gives a high excellent finish. Why heated composites? Increase in the temperature leads to increase in the conversion rate of monomer to oligomer to the polymer. So it will be the increase the flow of composite gives less shrinkage. The second thing is the life duration required to polymerize the composite was significantly very less. Third is better flow, so better cavity adaptation and also the increased depth. The fourth thing is highly polishability. This is the warmer I am using to heat the composite. Finally, the finishing and polishing. Step 1 will be the gross finishing. Okay, I use sometimes the 12-fluted carbide bar and followed by this is from 3M. It is for the interdental area and the brownie which is from Shofu. This is to blend the enamel and the composite. The second step will be the pre-polishing with the spirals. The first one is the E-twist, the second one is the spirals 3M. The third one is the final polish for the glass finish. I use the polishing paste which is a diamond one with the gold buff. So this is the inch-hour images. Pre-hourly images of distal cavity in the forceps. See the white wing. You can appreciate some amount of remaining tendon is there over the pulp.